For those of you guys who don't know, Dave, he used to be an active member of our NJ Sports PT until I guess he was still pretty active when he was at Sacred Heart, and then he now he's back in the area and the with the New York Mets and the HSS. But I'll let him kind of go into his whole bio and background in a little bit more detail, and then he'll be talking to us about what's like working in in the Major League Baseball and the minor leagues, and also like the difference between sports residencies and sports fellowships, which he's had a personal experience in. So, Dave, I'll let you take it away.
Yeah, thanks, Ed. It's pretty cool for me because, like Ed said, like 2.5 years ago, 3 years ago, I was on these calls trying to figure out how to get into professional sports, like talking about like if there's residencies in New Jersey and everything like that. And now I'm on the kind of on the other side of it, so it's definitely cool to come back here and kind of talk about my experiences. So like what you were saying, I was going to talk about like working in Major League Baseball and then also just like working as like a sports physical therapist and I'll talk about some different residencies. I know you guys had a call. Last call was about residencies, but I'll just quickly dive into a background on residencies, why I chose the residency I did, and kind of we can go from there. So like my agenda, we're going to discuss my background. We're going to review physical therapy residencies and fellowships and why I chose the residencies I did. I'm going to discuss what it's like working in minor league baseball, and then we'll do a Q&A session at the end. If anyone has any questions during the presentation, feel free to jump in. So right, my background, I was born and raised in Northern New Jersey, played 3 sports. So played football, wrestling, and baseball. So kind of knew that I wanted to stay within the sports realm. Wasn't good enough to play any college sports. So that's why I chose exercise science. Went there, University of Delaware from 2015 to 2019. Then after Delaware, I applied to PT schools around like the North Jersey area. And I got accepted to Sacred Heart University. That was from 2019 to 2022. And at Sacred Heart, the 2 major league PTs at Sacred Heart at the Giants went to Sacred Heart. So we have a clinical rotation there every year where you're down there for 3 months during spring training. So this was kind of what I first really liked working professional sports. I knew I was between like football and baseball. So I applied to different clinicals, and the Giants, the one I got, and my experience here was really good. Saw like the ins and outs of working in baseball. And that was kind of set my passion. And I also started looking at what minor league PTs, like what route they took to get to the job they wanted. So once I was here, I knew I was going to graduate, and I saw a lot of the people did a residency. That's how they got jobs in baseball. So that's why I chose to do that. And then also I felt like I needed to learn a little more. So that's why I did a residency. And I'll talk about, there's not too many in our area. So I ended up going to Houston Methodist Baytown, which is, it was the first year that they were doing a full residency. So I was like the first student there. So that was a definitely cool experience. That led me to getting the fellowship, which I'm currently at, which is going to be at HSS for 6 months, and then currently 8 months with the Mets. So we'll dive into that a little more, but that's just my background. So you guys talked about physical therapy residencies last time. Essentially, I can just give the definition here for a second. Residency program is a professional plan learning experience comprised of curriculum encompassing the essential knowledges, skills, and responsibilities of an advanced physical therapist within a defined area of practice. So this is the website that I used to kind of research residencies. This is probably the best way you can get. You can get a list of the developing residencies, which ones are accredited and which ones are upcoming. And there's different links on that are bringing to the website that sees like how many, like what the pay is like, when it starts, and different deadlines here. So if you're interested in residencies, I would definitely recommend going, or fellowships, I would definitely recommend going onto this website. This is definitely the official website for residencies and fellowships. So before I came on here, I did some research on the if you guys are interested in sports physical therapy, there's basically, in my mind, 2 residencies that you can go down, or 2 paths. You can go with the orthopedic residency, or you can go the sports residency. So for the orthopedic residency, there's 160 accredited programs. When I looked at it, there was none in New Jersey. There's 3 developing New Jersey, but there's no accredited residencies. And then for sports, is a little less. So there's 76 accredited programs, 2 developing in New Jersey. I know HSS has one, which is in Manhattan, which is, relatively close to New Jersey, but there at this time, I don't think there's any accredited programs in New Jersey for orthopedics or residency. So I kind of dove into why I chose to do a residency. I went to the San Francisco Giants, and I really liked my time there. And I kind of chose that I wanted to work in minor league baseball, or have the opportunity to work in the professional sports environment. And then as a student, and the more research you do, you start looking up the people that the jobs you want, whether that be football PTs, baseball PTs, and you see a lot of them do residency. And then, as we know in PT school, it's really teaching you to take the boards. So it's a pretty broad topic of things you learn. So I felt like I wanted to kind of dive more into the sports realm. So that's why I chose to do a residency. And then essentially the different residencies I saw that people were doing was either orthopedic residency or a sports residency. So the reason I chose a sports residency is I wasn't an athletic trainer. And I know, I mean, multiple people talk about how valuable the training room experience is. So that's was a big advantage for the sports residency with orthopedic residency. I wanted that on the field hours. I wanted to like learn under an athletic trainer and get more of that emergency management aspect of physical therapy, which you don't really get exposed to in school. And I don't think you'll pick up too much in a clinic day to day. And so this is just, I mean, my opinion. I think just treating as a physical therapist, like you're going to learn a lot of the orthopedic stuff. And I know if you're doing orthopedic residency, you're going to get a better education and there's going to be learning modules. So you're going to continue that learning. But I think the sports residency for me was like, I really wanted that training room experience. So that was the reason I chose that. And like I said, I went to Houston Methodist Baytown. I was the first official resident there. I really enjoyed my experience. So I would work in Houston Methodist Baytown for about 35 hours a week. And then we were partnered with the local high school. So I would go to the high school on Tuesdays and Fridays afternoons, and I would help out in their high school training room. Down in Houston, it's a little different than New Jersey. They had a indoor practice football facility. They had training room. They had periods where it was called football, and they would just go there and train and go to get treatment. So it was a very different experience. It felt like a junior college when I was there, but it was an experience and just seeing the emergency management stuff. I would cover games. So I would like run on the field and kind of work on my emergency management skills, triaging and things like that. So really, and Houston Methodist has a pretty strong connections within baseball. So they're partnered with Houston Methodist, and they're actually developing a upper extremity fellowship within Houston Methodist. So we have a lot of connections there, and there was probably 8 to 10 people that are in minor league baseball that did the Houston Methodist residency. So that's another reason why I chose that. And then kind of led me to my next thing, which is the fellowship that I'm in now. So definition of the fellowship is a post-professional plan learning experience comprised of curriculum encompassing the essential knowledge, skills, and responsibilities of an advanced physical therapist within a defined area of subspecialty practice. So like I said, there's like orthopedic and sports for residency, and then for fellowship, in terms of the sporty ones, you're going to look at the sport D1 fellowship. So there's 7 accredited and 1 candidate here, and then the upper extremity fellowship, which is 5 accredited, 1 candidate, and 3 developing. So for the sports division 1, you're going to look more getting into basketball or football for the most part. And then the upper extremity fellowship is really trying to dive into baseball. So I'm like I said, I was from North Jersey, and I felt like I could have had a shot at getting some minor league jobs out of residency, especially with the connections Houston Methodist had. But this is the second year that they were doing this fellowship, and it was a chance for me to go home for 6 months. And I also grew up a Mets fan, so also work with the team that I grew up watching. So it was really the perfect experience for me. It was the second year they're doing it, and it was the first time there was like a full where it was like 6 months with HSS and then 8 months with the Mets. And the big reason I chose it is during residency, it was a lot more focused on knees. So I saw about like 50 to 60 ACLs, a lot of meniscuses. Really didn't see too much upper extremity. In my opinion, I think you have to be in the right type of setting to see a lot of upper extremity post-op. I saw some rotator cuffs there, but I saw like 2 elbows in my year there. So if you're working in minor league baseball, you're going to see a lot of elbow, a lot of Tommy Johns, a lot of shoulder injuries. So I felt like I needed to I didn't want my first time treating a full Tommy John to be when I was in baseball. Like I wanted to get the job and do a good job, not just kind of learn on the fly. So that's why I chose this fellowship, the HSS. And this is kind of my experience. So, like I said, the first 6 months was at HSS. This is my mentor, Terrence Croy, and he has a pretty like big Instagram called Life After the Knife. So he's really involved in working with baseball players. So essentially, I would learn under him for a couple hours a week, and then also just practice at HSS. And I would see 95% upper extremity. So I would see 14 to 16 upper extremity patients a day, and all mostly post-op, a lot of conservative, some conservative care, and then any baseball player that would come into the clinic, me and Terrence would co-treat. So this is a valuable experience because you get to see people at all different. Like you get to see someone that's immediate post-op, 6 weeks, 12 weeks, so you can really hone in your practice and start feel a lot of shoulders and a lot of elbows to see like where they should be and where they shouldn't be. So I feel like my feel for the shoulder and feel for the elbow got way better with this. We also did every Wednesday Mets home game. I was able to cover at the Major League Stadium. So that was super surreal. This is a picture of me and Terrence on City Field here. But essentially, we would go every Wednesday game. We'd get there around 5 o'clock and kind of see the day-to-day activities. We'd see people when they got hurt off the field, they'd come into the training room. And I was able to also just talk with all the athletic trainers and all the physical therapists, sports medicine, basically everyone in the major league training room. So it was funny because I kind of knew them more than I knew the minor league staff, which we was going to be working with for the next 8 months. And then we also did some studies down there too. So it was part of a research project. And there's also a curriculum there where I was doing readings and things like that to really hone in my skills. And basically the goal of the first 6 months at HSS is to prepare you to work in minor league baseball. And I think when I got to the Mets, I was definitely really prepared. We also would have meetings with the major league and minor league Mets staff so they can help me prepare for different things I'm going to see when I got down to Florida. So currently my day-to-day, we'd start our morning meetings around 7:20. So I usually get there a little early to work out and everything, but fill like typical things, try to fill the tubs, make sure everything's ready for the day. At 7:20, we'll talk about what the players are doing that day, any things that change from the day before. And just that would be like the physical therapist, the strength coaches, the pitching coach, the hitting coach, just all get together and kind of discuss the players and what the plan is for the day.
This is at their training center.
Yeah, this is going to be this is in Port St. Lucie.
Mhm.
So this is where the minor league spring training facility is, and it's right next to the major league facility. Right now, like we'll have the low A team plays out of there, and then the minor league facility is right next door. So we share the same fields, and we have access to low A and to rookie ball to help people for like different progressions. But basically, how the Mets work is, and if anyone gets hurt at the affiliates from rookie ball to AAA, they'll rehab with us. If it's more than, I mean, it all depends, but for the most part, if it's more than 6 weeks, they're going to come down work with us. So we see a lot of the post ops, a lot of elbows. We saw a lot of knees this year, which is pretty interesting. But basically, if you have surgery, you're going to be coming down with us. But we also saw some soft tissue stuff, some longer term hamstrings, obliques, lats. So I mean, this is what I feel like if you're working in the clinic, you don't really see all that soft tissue stuff. By the time they get to you and see the doctor and get PT scheduled, they're kind of farther along. So I think it's definitely cool to see some of those soft tissue injuries because I didn't see it much at HSS, as in being the hamstring, lat, and oblique. And this kind of goes to my other challenge too. You also get to see them, you get to see them 6 days per week. So your programming is very different. So at HSS, would see them twice a week. So for the most part, you can kind of keep your plan, the main things you're trying to hit. So you can keep your plan pretty similar. But when you're programming 6 days a week, you can't be doing the same exercises for the whole 6 days, or you're going to flare up a couple cuffs. So learning to program for 6 days a week, learning to program when they're throwing 6 days a week is just a very different thing that you're going to learn in the clinic. So after the 7:20 meeting, guys will start coming in at 7:30. For us, we usually have the guys that need more hands-on, the fresh post-ops, the guys that are pretty early on in their progressions and not doing any stuff on the field. Those guys will be there from like 7:30 to 9:30. And then we'll have the on-field group coming around 9:30. So we'll help with their activation. We'll help with anything they need to get ready to throw or hit or field that day. And then at 10:30, we'll all go on the field. The pitchers will do their throwing progression. The field guys will throw it too, and then they'll break off and go into their defensive work, hitting work, and everything like that. And then around 12 o'clock, everyone will come back in. They'll do their lift or their conditioning for the day. And then after that, they'll do whatever PT stuff they have. So that's kind of how we break it up. Activation, and then you'll do either your rehab or your on-field activities. And then you'll finish up with either lifting or conditioning. And then you'll do, if you need to, some PT stuff and recovery after that. So guys are usually getting done with recovery around like 3 o'clock. We'll do our notes. We usually do like planners for the week, and we'll do like calendars for the whole progression and calendars for the week for their exercises. So we'll adjust anything we need to do there, talk about what happened that day, and then we're pretty much done around 5 o'clock. So this is what the current schedule is. A little different during spring training. Definitely longer hours there. But that's kind of the day to day for us now. And I kind of touched on some of the different challenges that you have. I think programming 6 days a week, it doesn't sound like a lot, but it's very different than you're going to see in the clinic. The hours are definitely a little challenging. You're working Monday through Saturday. And like I said, like this is the best the schedule has been, is 7:30 to like 4 or 5. But definitely during spring training, you're there a little longer. Just more guys, and guys are starting to. There's only 6 weeks left in the season. So some guys that are hurt and not going to be back this game, so they went home to rehab. So we definitely have a little less guys at this point, but the hours are definitely they're definitely a little intense. And I think the soft tissue injuries, just treating those is super valuable. They definitely are less predictable. So we ran out planners for the week. So for like a Tommy John elbow, you kind of know how they're going to respond. So it's easier to map out the entire week. Versus like these hamstring injuries, like you have to kind of monitor within session. You have to see what exercises they tolerate well, what exercises they don't, and it has to be more of an adjustment. And so that's why you can only really program for like 1 or 2 days. So I think that was super valuable to learn. And that goes into my next point. Once you're there, you're doing everything for them. So you're developing their throwing programs, their hitting programs, fielding, running programs. You have to make sure that they're seeing their nutritionist. You have to make sure they're checking in with the mental skills coach. A lot of these guys speak Spanish, so you have to make sure that you have a translator there for if you have to meet with them. You have to. A lot of times, these guys need rides to the doctor's office. So you're really taking care of these guys. It's definitely like you're definitely doing a lot more than just treating them and running their PT progressions. So it's definitely a lot more. I mean, my Spanish has gotten better. But I didn't speak much Spanish going there. And it's definitely, you kind of have to learn to at least say a couple words, or you're going to kind of, that's another thing I should put on there is the language barrier. I would say 60% of our guys are mostly Spanish speaking. I mean, some speak English and Spanish, which is you rely on those guys to help you translate. But there's definitely a lot that goes into treating here. And I think the progressions are really fun to make, but also you'll put out a perfect throwing program that you think, and then the first day the guy is feeling a little tight here or it's not responding the way you expect, and you have to adjust. I think throwing programs people probably do in the clinic, but I think it's also different seeing them throw every day. And we also do a velo-based throwing program. So we'll get down there, we'll get behind them with like velo guns and see how hard they're throwing. We script this all out, so things will change on that, and you kind of see the responses where I think in the clinic, usually when they get to the throwing program, you're seeing them like once a week, twice a week, and they're doing a lot of this stuff on their own. So it's definitely interesting to see, like checking their range of motion the next day, like doing serial tests before they throw their bullpens. You get to see a lot of like the day-to-day stuff, which I think you don't typically see in the clinic. And then for the hitting progression, same thing. We're starting to use the blast a little more, which looks at your swing speed and looks at the amount of swings you take. So we're definitely a lot more sports science stuff than you would typically see. So just getting used to all of that. Same thing with fielding, looking at different workloads that you have to get to. And the running progressions, we do it all based off GPS. Look at the previous norms and try to scale it that way. So there's just a lot of different technologies and things that you have to learn throughout the way. But I think it just makes you just overall a better clinician. So that's kind of what it's like working in baseball. And then I can't speak on the major league level, but this is what the minor league looked like. And it's also very different it's interesting to hear from different organizations because a lot of organizations do it very differently. We have a lot of fancy toys, and I think our sports science department is really top notch. So we have a lot of different data. Like we said, like a lot of our stuff, like our throwing programs are velo based. Our hitting progressions are based off the blast, and then the running progression based off GPS. So there's just so much sports science, and I think that's how PT is going. Is a lot is using all these. We have a lot of technology, just figuring out which things are important, which things are not so important. But I think
So
that's
do
one
you
of
have to do you incorporate that data, or do you have to take it and then report it to like the analytics guy, or like
so
how do you guys work with the analytics team?
yeah, so essentially, I don't know if you know like a force frame is, or like something that you basically just can measure force and it's like it's fixed object. Once we do that, so we'll do that. We'll look at rotator cuff strength. We'll look at hip strength. That gets input into a computer and it goes right to it's like a performance dash. It's kind of like it kind of looks like a Facebook page for a player. So it'll say Ed in the left corner, and then it'll have rotator cuff strength down there, so you can see it. So after 15 minutes of it doing the test, you'll put it and you can look at it. So we'll use those tests to see in the beginning. We have their previous norms. We'll do it during spring training. So we're trying to get within 80% of that before they start their throwing progression. And then we'll also look at that as they do their throwing progression. We'll look at their rotator cuff strength, for example, like every 2 weeks to see how they're trending, whether they are trending up and they can kind of push a little more, and or if they're going down, you have to figure out, well, are we doing too much with arm care? Do we need more arm care? So it's definitely cool to see those trends throughout the throwing progression. So that's how we use that. We have a sports scientist in rehab that will send an email every day too that reflects like, hey, this player's shoulder pin flexion was down 12 degrees. His grip strength was down this. So you can you get that sent to us through a sports scientist, and you adjust your plans there. So there's a lot of data. So you got to figure out which things are important and which things are not so important.
So you guys do baselines on all the players before at the beginning of the season, so you have something
Yeah.
to compare to.
Yeah. So for spring training, we'll do your typical range of motion, shoulder, hips, and then we'll do hip testing, ABAD, and hamstring, and then we'll look at their rotator cuff strength and grip strength, to name a few of the tests. So then we'll have that for their spring training norms, and then because we've been doing it for a fair amount of time, we'll have the averages for the organization. So like it'll be black if it's normal, blue if it's not enough, and then red if it's like above everything. And then we can look at that compared to norms, and then also to themselves when we're running return to sport progressions. We'll try to get that previous data. So if it's an oblique, we're going to want 80% strength of their previous norms before they start like a hitting progression or throwing progression, for example. That's kind of how we're using it. And I know some teams are not as objective as we are. I think I see both sides of it. If you think you're running a good gradual, like people have gotten people better without all the science and all the data. But I think it's nice. I mean, you write a good PT progression, you think your numbers should reflect that. So it's definitely kind of just checking your work on that. But I do see the argument of kind of over testing and over analyzing things. So it's definitely a happy medium.
I mean, you're never going to get in a situation where the analytics guy's like, well, their internal rotation is a little weak at this angle. Can you work on that? Like, they're not dictating what you guys are doing. It's that.
Right. I think it's more like sometimes the players get a little like, hey, like if my numbers are totally down, then you're gonna change my progression. So like they get a little like worried about that. So I think you just gotta communicate like why you're looking at it, and then also like if someone's numbers drop, you don't have to totally change the progression. So I think just getting the players to like not think of it as a punishment, think of it just like we're just checking in with them to make sure what they're saying is matching objectively.
Do you find that because you guys are programming 6 days a week, do you find that you guys can go a little bit more aggressive because you can tone them down if it's a little too much, or do you find that like because you're doing 6 days a week, you're a little bit more conservative? I would think more aggressive just because you can always tune it down a bit. But what would you say about that?
Yeah, and I think that's why we do 6 days a week. And then when the major league guys are down here, they're doing 7 days a week. Every day is dollar. So especially for these soft tissue injuries, you can definitely progress something way quicker, especially if they respond well on that Monday. They come back Tuesday and they're feeling pretty good, no soreness. Okay, we're gonna kind of push them. That's why I think the soft tissue injury is a little different. I would say for the surgeries, when we kind of know like they're pretty predictable, so we'll kind of keep them and we'll change things within session. But for Tommy John, the return to sport is around 14 months. Like we're not going to make up too much time with that, nor I think we really should. There's just a healing component to it, but I think definitely like for those soft tissue injuries where you can kind of get them back and you're missing games, you can get them back quicker. I think that's where that's why you're doing 6 days a week is so you can be
Right.
more aggressive on that. Yeah, definitely.
Plus, those are the things that lead to compensations and then major injuries, right?
Right. Yeah, 100%.
Cool. So when you're in Florida, how long are you in Florida for with the minors?
It's gonna be 8 months when it's all said and done. I got there early February, and then I'll be done September 30th. So that runs pretty much throughout the whole season. And then after the season, a lot of guys will start, like the surgical guys will stay there, but the guys that were rehabbing to get back to games, they can do rehab at home. And then for us, like November, there's a dead period in end of November through January where guys are home for 5 to 6 weeks. So we're kind of making sure that they get the PT they need. And then the year would start like around January 6th for most teams.
Do the Mets have any minor leagues closer to the main team?
Yeah, so they got Syracuse is the AAA team, Binghamton, New York is AA, Brooklyn is low A, and then Port St. Lucie, the low A team plays in the big league spring training facility. Then you have rookie ball, which will be in the where we work now. So we'll always have teams in and out of there. So we'll help out those guys, and that's also when you're making a progression, you can just have them play in the rookie ball. And then we have two teams in the DR. So another part of the fellowship was I was able to go to the DR for a week. And I actually served as an athletic trainer down there. So it was cool. Not knowing the language, two, just having different culture, and then also three, being an AT down there. So it was a really cool experience, and they have a really good program there. And there's a bunch of big league teams that all have complexes right next to each other. So that was a really cool experience. And I think just experiencing people with all different cultures, backgrounds, I've really enjoyed that aspect of it.
So when you're in the fellowship, are you working under like a another sports physical therapist, or are you sometimes directly supervised by like an athletic trainer?
For when I was at HSS, I was pretty much just a normal clinician, but Terrence was my mentor, so he would help me out with different things. And then we have the way the Mets structure it is we have a minor league coordinator. So he's a PT and he oversees. There's two full-time PTs and the fellow, so he's kind of our direct superior. So he helps us with the progressions. Like he has the final say. So like we'll write out the calendar, write out the planner, and he'll kind of check our work. And he's the one that's really communicating with front office, the different game progressions and stuff like that. So I know some teams just have three PTs and they all kind of share those roles, but for the Mets they have one coordinator above us, and three PTs. So he'll be my direct. He like leads the fellowship when I'm with the Mets essentially, and then Terrence at HSS will lead it when I'm at HSS.
Okay. But he's more based up here while you're in Florida, right?
Yeah. So the coordinator he's basically my main contact in Florida. Yeah, he oversees everything. He's in the complex.
Oh, okay. The how do you find that I remember you were talking about the residencies and like doing ATC work, and obviously before residencies were a lot more prominent, like a lot of people would do their ATCs or PTs along with it. How do you see that transitioning, and how do you find the major league teams or the minor league teams are kind of like bringing in like more sports PTs versus the ATs, or do they still kind of favor athletic trainers over like sports trained physical therapists?
Yeah, so what I've been told is like football and hockey, they're gonna definitely be more still PT AT focused because that's a lot more like emergency management. Where like basketball and baseball are definitely more like long term injuries, chronic injuries. So I think baseball in particular is definitely open to just the AT, or sorry, just the PT, because you're getting a lot more of those long term rehabs. Where in football you're getting a lot more of that emergency management. They want you to also do on field coverage. But especially with ATs kind of shifting to getting your masters, I think there's definitely going to be, it's going to be harder to be an AT and a PT because you got to get your master's in athletic training, then your doctorate in physical therapy. So I think it was a big part of what I was missing. Just like the day-to-day stuff, the ankle taping, what you do, like you see that a lot, like removing stitches or just wound care in general. And you'll see that a lot. Like a guy will come in, like have a cut on their hand, like you have to help clean it up, and you just don't see that in PT school. So also like I've covered some games in the Dominican, and you have to I had to do like emergency management, so you don't get that in a regular clinic. So just knowing like the different rules you have to do and things like that, I think it was super valuable. I think my time in the training room with the Giants, and then I think my time during the residency has really changed how I practice, especially with emergency management stuff. And you see some of those small injuries. I feel like when you're just in a PT clinic, you're just always used to the ones that are going to be like really like long-term stuff. Like you also see some of the like the hamstrings that go back in 2 weeks, which you really never see. So it's definitely different there. And then I think evaluating is super important. When you're the first line, you have to triage them to see if they should see a doctor, if they're good to go. I think in the PT clinic, they've already seen by a doctor. So I mean, I think your evaluating skills are important, but I think just triaging it to the next level was something super valuable for me. And doing a quick dirty eval, be like, okay, yeah, I think you're good to go back in the field, like, or you have to see the doctor. I think that was like those things that were super valuable to me that I had to learn a lot. It just you need a different evaluation skill when you're on a bench. You got 5 minutes to make a decision versus when you're in the clinic, you have an hour to do the eval and then just get an HEP. So it's just a very different aspect that the trainers have to work in. And I think I learned a ton from the athletic trainers, and I think it's cool, like we talked about with rookie ball, like they're in the same clinic. So we're watching what the ATs are doing pretty much every day. So we work hand in hand with them. We'll help out. They help the guys and they'll help out with the rehab guys. So I think the athletic trainers do a great job. And the emergency management thing is still, I think ATs are always going to be better at that than the PTs. So I think just relying on them, learning a lot from them has really helped me.
Cool. Yeah. So do you think, do you have any pearls for us that you've learned from anybody down with your experience with HSS or the Mets in Florida?
Yeah, I wrote that in the email. I think just like loading the tissue appropriately is like super important. Especially I feel like at HSS, we were just like you can really load like shoulders and rotator cuffs. Like I think we would do like bands and we would do like heavier, like we do some heavier stuff, but like especially with Ashworth, he has a lot of good stuff on loading shoulders, anterior shoulder endurance tests. I know he's been posting about that. We've been using more of the ASH test too to look at the TJs and look at some labor stuff. So you can really load the specific tissue that you're looking for more than you think. And I think in PT school they always said like you can probably load your patients more than you do. And I think I've loaded shoulders way heavier than I've ever had before, and guys respond super well. So I think loading the tissue of importance is super important. And I know in PT school they talk about regional interdependence, and I also took an SFMA course. So I was definitely looking at the whole body, which I think is important. But I think at the end of the day, especially if they're coming with a hamstring injury, I know there's things that can help prevent these hamstring injuries, but you have to make sure you're loading that hamstring tendon appropriately, and it's getting a good response. So I think local tissue loading is super important, and knowing that you can load it probably more than you think.
Yeah, I guess especially at that level, it's like you don't want to just be gentle with it. You got to make sure they can handle what they're pounding on the field so that they don't hurt themselves, right? So
right, especially for hamstrings, like running is going to be whatever you do in the weight room. There's probably no chance that you're getting close to that. What running is going to be on the hamstring, so you got to prepare them to get back to those running progressions. So you definitely got to load the hamstrings pretty heavy.
cool. So anything else about like your take on the fellowship versus the residencies? Like I know you did a lot of the sideline stuff you said during the residencies. Did they do a lot of that, or did they focus more on the fine tune like functional rehab for sports in the fellowship?
In the fellowship, I didn't do really much on-field coverage. It was mostly, so that was the difference. For the residency, I was definitely doing a lot more training room and clinic. HSS was mostly clinic / preparing you for the Mets. And with the Mets, I'm mostly functioning as a PT. So I think the residency was definitely more of that like emergency management athletic training part of it, where the fellowship was more diving into like the nitty-gritty of treating in baseball.
Mm-hmm.
And just I think in terms of upper extremity fellowships in general, they're just growing. I know there's like I think 3 are just getting added. It's a couple different organizations, so I think there's going to be like 8 maybe 8 to 10 fellowships. So, and the way I see it is like if you're gonna have 8 to 10 fellows who are trained specifically in baseball, it's gonna be pretty tough to get a job in baseball without being fellowship trained, just because there's people that have already have a year of experience and specialize in treating with that. So 10 of us are gonna be looking for the 3 or 4 jobs that open up next year, and then the class last year, there's probably 5 or 6 people that did a fellowship that didn't have a job in baseball. So I think a lot of the teams are going to look for the residency fellowship trained people because they know they're prepared to meet the demands of what they're looking for. So I think it's just super interesting, and it's how many are. It's just a growing thing. The fellowships.
Yeah, especially if it's like even if the Mets don't have a position, I'm sure people are like, hey, you guys run the fellowship program. Well, how's your latest guy, Dave? And hey, we got an opening. Can you send him down for an interview? Like
Yeah, exactly, and that's definitely going to be happening. I know it happened to our last fellow is working with the Orioles now, so that exact thing you said is they did the fellowship and they reached out and he got a job with the Orioles. So I definitely think that's going to happen.
I think
With
it's definitely a
fellowships.
fast track. Like I know, like I think it's his name is Ryan Brooks, and he's the PT for rehab for the Rutgers football team, and I think he did
Yeah.
exactly that. Like residency, right into a fellowship, and straight to like Rutgers football. Like it was one after another.
Yeah, exactly. I mean, I don't have a full-time position now, but within a year and a half, I was already treating the sport I wanted to be in, and also with the team I grew up watching. So it worked out pretty well for me doing the residency fellowship route. And you just realize, like, through the residency and fellowship, I probably know people on 10 to 12 teams in the PT department. So you just learn. Like, I think 2 people when I was a student with the Giants. One works with the Astros and one works with the Cardinals. So there was 3 months there, and I already know 2 people that are in different organizations. So word travels pretty quick. So it's pretty interesting to see how that.
Those are good contacts to keep, obviously, because they'll have their ears to the ground for the next opening somewhere close to them.
Exactly. Yeah.
And I'm sure like you get to meet the guys in the same position in other teams when you're down in Florida. You said that that facility houses are really close to some of the other minor league teams, right? You said.
That's mostly the DR. The DR is closer. I would
Okay.
say the Mets are in a little weird area. I think a lot more teams are like the West Palm Jupiter area in terms of on the east of Florida, and then the Sarasota area is a lot of teams. But you definitely hear their names, and I know a couple people that are in the area, so you can like hang out with them and kind of pick their brains of things they're doing, their different experiences, how they go about things. So I think it's a pretty small world once you really get into the sports world.
Yeah, that's pretty awesome. It's like, and would you say baseball was your favorite sport out of the three that you played in high school?
I would say football is probably my favorite. Wrestling was definitely my best, and then baseball was I'm treating in. So it all worked out for me in the end, all 3 sports. But I definitely think football is my favorite.
Mhm. Cool. But definitely like in terms of your specialization, it seems like you're definitely doing like the baseball specialization. That's kind of your foot in the door with both the Giants and like the Mets now. So I mean, usually that's still great to get into other like sports areas, but obviously you've already done a few seasons or a few years with their system, right? So you kind of know the inner workings already.
Yeah, I think that's part of the fellowship is you're going to be specializing in the area. So I feel pretty super confident, and I think baseball in specific. I think the elbow and shoulder definitely you don't get that as much in like other sports. Like for basketball, you think more lower extremity. I mean, football lower extremity, but you also have a couple upper extremity things. But I think treating like the baseball athlete, I don't think people get much experience with it in a clinic because usually the surgeons that are doing a lot of these elbows, they don't want to send them out to just anybody to do like their first time in
Right.
John. They want people that have been treating them before.
Mhm.
And I've noticed that, and especially I think a cool part of HSS is the surgeons will at like the 5.5 month mark they'll send like if their athlete wasn't rehabbing with us they'll come at HSS to do like return to sport, and we'll look at their rotator cuff strength, look at their range of motion, and ask them what they're doing. So you get to hear all the different stories of how they've been treating, and if the data doesn't lie, if you're I think internal rotation strength is probably the thing that's underloaded the most. So they'll have a 30% deficit in internal rotation strength. So based on what Terrence was asking them, like what steps they had missed. I think it was super interesting part is like obviously you just whatever Terrence says they're missing, then you know that to add into your program. So that was a super cool thing is doing the return to sport testing and just seeing a ton of different people at the throwing mark and seeing which ones were repaired and which ones aren't.
And then they have like objective numbers to kind of back up all those things, not just like manual muscle testing. Yeah, the guy's weak. Let's go through strengthening. Like you can actually put a number to it and then compare you have the baselines too, which is awesome. Like because you
Right.
can show the athletes like, look, you were definitely way better like a few months ago or a few weeks ago. So we got to build you back up.
Yeah, and I think the big thing with that is just being strict on your return to throw criteria. Like it's 10 when it was at HSS within 10% of your other side, and if it was a more deficit, you weren't throwing. I think being strict at that because like if you start saying 12% and then like all of a sudden it's like 15. So I think at Houston Methodist I looked at a lot of things and wasn't strict on things. Like I was looking at like single leg balance and like wide balance for person that's returning from Tommy John, and if a 13 or 14-year-old kid is probably not going to pass those. So like I think just testing the things that you're going to say, hey, if you don't hit this data, you're not going to get back to throwing is super important. I think looking at the other stuff is nice. We should have a couple things that like, hey, these are non-negotiables. If it's not within 10%, we're not comfortable with you throwing. If you didn't do two-handed plyos, you didn't do one-handed plyos, you're just not there yet. You can fast track it, but there's just some non-negotiables that you have to have in your upper extremity rehab programs.
Cool. How involved are you guys with like the rehab league? When they first start trying, let's say they're rehabbing their shoulder and they're getting back into it, like, do they expect you to kind of say, give recommendations on pitch counts or what to look for? Or do they like, hey, when you're done with them, tell them when he's ready for rehab league, kind of, and then take it from there?
So for like we'll write their entire like throwing progression. All right, like we'll write their throwing progression, then we'll write their game progression too. So like we'll script like, hey, you got 20 pitches or like one inning. So we'll kind of be strict on that, and then usually their rehab. Like, I think you have like 30 days you can be on a rehab assignment before you have to put on a roster. So for those first 30 days, once they cleared the live pitching and they get back into games, we're kind of scripting how many pitches, and with help with the pitching coach, the rehab pitching coach is going to help us with that too, obviously, and kind of determine different needs for the different teams and stuff like that. But we're definitely keeping a pretty close eye on them in the first month, and then after that, they become a healthy guy, and the pitching coaches are aware that they're coming off surgery, but the pitching coaches and the teams will kind of take over depending on need, whether they're starter, reliever, things like that.
All right, cool. Anything else you think would be interesting for our listeners, or anything else you want to mention?
Yeah, I mean, if anyone has any questions now, glad to hear them.
Yeah, open up the floor to anybody else who has questions for Dave.
Hey Dave, this is Bruce. I'm with Kessler Rehab.
They
I
do.
heard you talk about the force frame. You guys use all the Vald testing stuff like force decks and dynamo and such like that.
We actually use a thing called the Kang Attack. I'd say it's pretty similar to the HSS we're using the force frames. I would say it's pretty similar. The Kang Attack has a little more training features, which is kind of cool. So you can trade like hamstring loading and things like that. And then we have the force plates. We have I forget what it's called, that the grip test that you can look at. That's electronic. We'll have that. We have a lot of different things. But yeah, I would say we use the Kang Attack, which is basically the force frame. And I think that's a really good way to look at shoulder strength.
Yeah, and then so like, how are you relating that to your program? Like one thing that I find is difficult, like obviously a lot of those are ISO tests. So let's say they test that, I don't know, whatever, 20 pounds on their internal rotation on their ISO. Are you looking at that and saying, well, okay, now I'm going to give them, let's say 15 pounds through the range, or like, how are you deciding that, using the objective data to look at what you're doing with them in rehab?
Yeah, so I think the big thing for us is like we have doctors that are going to help us with our prognosis and when we think they're going to get back. I think just having like when you set like say, hey, this guy is going to throw around 6 weeks, he's going to be down for 6 weeks. He's going to start throwing progression here. This is the objective data we need to hit. So we'll say, and we'll have their previous numbers, but if you don't, you do the other side. Like, hey, he needs to have within 10% of his other side rotator cuff strength, and then you work backwards from there. So that's like your end goal in terms of getting him back to throwing, and then you build out your rehab progressions. Like, okay, well, we know he has to load it. He has to start. Like, say it was an injury, he has to start But the first week we'll have to start the cuff down here, just isometrics. The second week you can start doing concentrics down here. Then the third week you move up to isometrics at 90, start doing more concentric stuff there. So I think you'll have that objective criteria as like, hey, this is what I need to get before I start to throw, and then you can build back your throwing your rehab progressions from there. Same things like with the two-handed plyos, one-handed plyos. Like, hey, before he has to get throwing, he has to do one-handed plyos, let's do two-handed plyos. So find the mark where you think he's going to be ready to go, have objective data that you need to hit before you start the throwing progression, figure out what things you have to see within the session, one-handed plyos, two-handed plyos before you get there, and then build back your rehab progression. I think that's one thing I learned with the Mets is finding, like, start with the end in mind. Start, hey, when I want to do throwing, when do I want to finish the progression? Then you can work your way backwards to where you're at that current state. And knowing the first 2 weeks sometimes are probably going to be just letting things scar down and things like that.
Yeah, gotcha. Okay, so it's not necessarily based on their ISO strength.
That's the I think
that's the end test. That's not really the
that'll be the return to the throwing testing. I know what you're saying in terms of like we want to look at things like we know that their strength isn't like you're gonna be when you're throwing, you're gonna be using it concentrically, eccentrically. I think the gold standard right now is the max isometric test. I know some teams, especially for like the knee, people are looking at more like isokinetic test. I just don't think the data is there for the shoulder. Nor I don't know how like comfortable surgeons will be doing like isokinetic tests on the shoulder elbow, but I think it's a good idea. But yeah, for right now, I think our isometric test is our gold standard, and that's what we kind of base things off, knowing that like you're going to train eccentrically, you're going to train the plyometrics, but we also don't really have a great way to test it. So for us, it's rotator cuff strength, internal, external. The prone endurance test are the things we need to see before they get back to throwing, and we're also looking at a bunch of different things in terms of like lower extremity and things like that. But those are our non-negotiables for getting back to throwing.
Yeah, great. And how long do you see like a person for a single session that's doing 6 days a week? How long is there each session in a day? Are they doing like an hour and a half, 2 hours generally?
Right. So we have two groups right now. So like the activation time will be 7:30. So activation is usually from 7:30 to 8:30. But it's not like your normal clinic where someone's coming in a half hour. Like if you have 3 guys in group 1, they're all coming at 7:30. So you just got to kind of plan your activation around that. So they're doing an hour for activation. For the surgical group, it's less activation. They're not getting ready for the gym. So you're kind of just you'll do your passive range of motion. You'll do small things like that. And then typically it's going to be 7:30 to 8:30 is going to be your activation where you're doing your movement prep, you're doing your lower extremity stuff. And then from 8:30 to 9:30 is going to be their lift or conditioning for the day. And then at 9:30, they'll come back in and finish up whatever they have left for the rehab. So they're there probably 3 to 4 hours after the recovery modalities. And then the on-field group, it all depends on if they had a bullpen that day, if they had a light day of throwing. Their rehabs are going to be pretty light. They're probably going to do recovery so they can get in and out within like 2 or 3 hours. But then if you're having like a live, we're going to try to keep like your heavy days like heavy. So you'll do your dynamic, you'll do like your heavy throwing, you'll lift after you throw your bullpen, you'll do your heavy rotator cuff and forearm stuff. Then you'll do like probably a lot of recovery. So you're there for a little longer, and that's trying to resemble like a game day. So those guys will be there 4 hours, around 4 to 5 hours. And some guys aren't the fastest moving, so they take their time. They get free breakfast. They get free breakfast and free lunch, so they're not necessarily trying to get out of there too quick.
Yeah. Yeah. And do you do the wellness recovery and stuff with them, or you only take injured guys?
What'd you say?
Do you do like wellness, like with guys who aren't injured, or who handles that? Or you only handle injured guys?
I would say the athletic trainers are mostly doing the wellness, but kind of like I said, like we have the draft guys come in now, so they need some more structure. So they don't know who's who, so we're definitely helping out with them, and it's pretty fluent. Like if a healthy guy needs soft tissue, they need help with their program, help their exercises, and we're available. We'll definitely help out with them. And then we'll also help out. But we have like screening, like MSKs we call them. So looking at the range of motion and stuff like that, we'll help out with the healthy guys there. And during spring training, we'll do all the tests with healthy guys. But for the most part, we're dealing with the guys that are out for 6 weeks and not too happy. So
Yeah.
When you say activation, is that something that they've already pre-set up, or is that you're getting them to do the activation, or is that something like strength and conditioning does for them, or
Yeah, so we'll plan that out. So we have like an Excel calendar. It'll say like activation and then rehab, and then at the bottom will be their S&C stuff. So kind of going back to like the MSK, like we did on spring training, say their hips are tight or their hamstrings tight, like that's the time where you're kind of working on some of the mobility stuff, tissue prep, like doing some foam rolling stuff on their pack, but trying to make it individualized. So like everyone's not doing the hip mobility drill. If your hips mobility is good, then you're probably doing a little more activation stuff. I'd say it's a little different. Like for the what I was saying, like the post-op guys, they don't really have one because they're basically just they can't do much. So you're just kind of focusing on that local joint. But for the throwing guys, like they usually have their own routine. So once they get healthy, they'll go through what they do, and like that can be a heat pack, that can be laser, that could be a Theragun, whatever they kind of need to get ready. Um, so it usually starts with a modality or two, some soft tissue, hip mobility, some activation, whatever, and then they'll do the bands on the field too, and they'll also do movement prep when they get to the field, as in like water bags and like what you see like Paul Scene's doing with those aqua bags. Like we're doing that all too.
yeah, without you said you're down there with the which level are you with in Florida? The the AAA or
It'll be anyone that gets hurt from AAA to rookie ball will come rehab with us.
okay. But
Yeah.
the so you're not in a league, it's more just like the rehab facility for anybody who's hurt from those.
Yeah, it's anyone that's hurt or like the rookie ball will be out of our facility too.
Do they have like so would they also have a PT for every single of the like the double A, triple A, or just with you guys?
No, so they'll have an associate and an athletic trainer in every facility. I do think in terms of where that's going, I think there's going to be some more PT, AT. There's going to be more PTs in AAA. I know a couple of teams are starting to look into that. Just to kind of bridge the gap, just having someone up there that has a different skill set and keep some of those long-term rehabs. I think that's where potentially baseball will be going. So I think it'll be a cool opportunity for some people. But for right now, we have two ATs at every affiliate.
Mhm. Yeah, because I think I mean, obviously part of it is the pay because obviously all the education for both ATs and PTs have gone up a lot, and the PT salaries are, you know, you can argue has gone up a bit, but probably not enough. But then the ATs are also trying to play catch up, so I think it's tough. And obviously, when they're looking at budgets, they're looking at, well, if I can pay someone like AT salary versus PT, like sometimes they just say, well, or they'll just say, hey, we'll pay you as an AT if you still want to work for us as a PT, but that's what you're choosing a lower salary, obviously, to work with athletes.
Right.
Do you,
I definitely think that's a big problem that people are going to be facing.
yeah, these I know, like even with the Patriots, like in the ball TD Bank ballpark, like they just added on like a an AT, so they have two AT nows, which is great because they only had the one guy before, and now like even PTs, they don't really have like, and just like you probably know, like any professional league is very closed off, so they don't kind of want anybody outside the inner circle to know what's going on. So unless you're actually on the team, they don't really have like, and we're literally in the ballpark, and they're like, we're good, you know. Whereas before, when they were part of the Atlantic League, we would help out and we treat the players. Now they're like, yeah, you know, we're good. If we need anything, we'll call up like Eric Cressy or, you know, the top guys, like, you know, in your case, like Terrence, if they really need anything, because like, you know, just everybody kind of wants to get their foot in the door. So they kind of just have everything closed off until again, you get in there, like if you're on a fellowship or whatnot, I think.
Yeah, I think staffs are just growing also in baseball. I think a lot of teams want to keep things in house. I mean, you just seen 6 years ago, like Terrence was treating a lot of like the big league guys.
Mhm.
So I think they're trying to keep things in house a little more,
Mhm.
which is it's good for like there's gonna be more jobs available within the sports, and but it's not as good for the guys that are trying to like see some of those professional guys. But I also think players also want more hands-on treatment now more than ever. So I think that's also going to help. If players are complaining they're not getting enough hands-on time, then maybe they add a couple of people. So I think just I know like the Mets department is growing. I know the Giants department is growing a ton since I've been there. Adding PTs in particular. So I think the staffs are going to grow as uh, there's more money and we people want more hands-on. So I think that's good for if you're trying to get into professional sport, just having more jobs opening.
Who's the main orthopedist for the Mets right now?
So it's changed. I think Dr. Carr, who's based out of based out of Florida. He's moving to New York. He's moving to New York this month, so he's the guy that we go to mostly. He was in West Palm Beach, but yeah.
But he's moving up to New York to be the main guy for the Mets, I guess.
Yeah, I'm not entirely sure. I know, but he's done a lot of our elbows this year, and I know he's moving up to Manhattan to start practicing there.
Do you know if the Mets use a lot of like James Andrews, like like his name's been tossed around forever for Major League Baseball. Like, does he still do a lot of the Major League consult, like second opinions or whatnot? Do you know? Or
I would say for us this year, Dr. Meister did a lot of the consults, and he did a lot of our elbows this year too. So I think he's one of the main guys right now to go to.
Okay. He's like, at some point, I think everybody for every sport was like seeing James Andrews for a second opinion. And I think he's got to be old now. So it's like he's probably winding down.
I think he might have retired a couple years ago, to be honest.
That's probably why we haven't heard him in the news as much.
Yeah.
Cool. All right. So unless anybody else have any other questions for Dave about Major League Baseball or fellowships? No. All right. Dave, if you could like just email me, like, you mentioned some of my Instagram posts and some of the guys to kind of look out for some of the newer stuff, especially with the data analytics. Like, that'd be great if I can kind of just share that with people, like just, interesting stuff to look up to see what kind of stuff you guys are doing, the majors and minors, and then I'll be able to just add it to the presentation or something.
Yeah, that's perfect. I know Terrence posts a lot of stuff on his Instagram, and I'll definitely appreciate the followers. So
Yeah,
I'll send you his Instagram, and I can send you my phone number too if anyone wants to reach out and kind of discuss this further or ask any more like I guess personal questions about the job. I'll definitely put my phone number in that email too.
All right, awesome. Well, thank you very much. That was very informative, and I'm glad you could join us. And
yeah, for sure.
good luck with everything. I'm sure I can't wait to hear where you end up in the next few months, because I'm sure.
I'd rather keep you updated.
Yeah, awesome. So take care, and thanks for taking the time to speak with us. And I'll show you the posting before I put it up on the line.
Perfect. All right. Yeah, appreciate it.
All right. Thanks a lot. Have a good night, everybody.
You too.